afternoon, everyone. This is Claudette Fonchel from Healthcare Improvement Foundation, and I want to welcome everybody to this afternoon's webinar. It's the webinar on the 2017 Delaware Valley Patient Safety and Quality Award Winners webinar. That was a mouthful. This webinar will be 1 hour in length with presentations from some of our top 10 winners. And we will take about 45 minutes to go through the presentations and then leave some time for questions at the end. Just to let you know, in 2017, we had 31 submissions to the Patient Safety and Quality Award from 10 Partnership for Patient Care contributing organizations. And as we continue to say, the submissions and the awards that are coming in continue to impress us with the great work that is happening here in the Delaware Valley region, in this 5-county region. So the Delaware Valley Patient Safety and Quality Award, just to give you a little overview, it's been hosted by Healthcare Improvement Foundation since 2002. It recognizes hospitals and other providers for their innovative contributions in advancing patient care. It promotes best practices in patient safety and quality throughout the region. And the award program is funded through the Partnership for Patient Care program. PPC is what we call that, and PPC is a collaborative between Independence Blue Cross and the Philadelphia region's hospitals, and it's managed, again, here by HCIF. So some of the criteria for the award winners is that we had, that we reviewed that they were replicable programs, that they were innovative projects. It was work that was being done at organizations that's current, and when we say current, we usually mean within the year, that it has a collaborative approach, and that there is a senior leadership commitment to these programs and these projects. I do have some technical housekeeping items for you. I just want to mention that Zoom is a new platform for us. So please bear with us if you have any kind of technical difficulties. We will be monitoring the chat and question and answer box if you have any difficulties, and we will do our best to respond as quick as possible. You can access your audio for this webinar through your computer or your telephone. However, all questions must be entered through the Q&A box, and you might need to look for this on your menu bar. Today's webinar will be recorded, and we will send it out to you so you can share it with your colleagues, along with a PDF from today's slides. And later today, you will be receiving a short evaluation via email from Liz Owens, and we please ask you to take the time to fill this out. There is one quick poll question for you in regards to how many people are participating on this webinar with you, and again, also, please take a moment to answer that. And while you listen to our speakers, I want you to think about a few things. After listening to these presentations, I'd like you to pull out some highlights for yourself that you think are important for you to share with your organization. That is the purpose of today's webinar. It's to share this great innovative work. We would also ask you to think and see if you can identify some of the key factors that made these projects so successful. And lastly, I'd like you to think about how these projects can be replicated in your organizations. You know, is this something that you are focusing on, and is something that you can carry through your organization? So at this time, I'm going to remind all of today's speakers to make sure you take a moment to introduce yourself. You might want to mention your role in this award submission. And at that moment, I'm going to hand this off to you, Dr. Murley, and there we go. We had your Jefferson slide, and I'll hand it off to you.
Okay, thank you, Claudette. Thank you very much. My name is Dr. Gino Murley. I'm at Thomas Jefferson University Hospital here in Philadelphia, and the project that we're presenting is on behalf of our blood management team to improve blood management here at Jefferson. So I'll move to the next slide. So the goals of our program was to develop a hospital-wide blood management program as a team effort, and this was interdisciplinary and had our support from executive engagement from the senior leadership here at Jefferson. And our focus was on length of stay for the patients with respect to blood transfusion, and also to look at known transfusion-related complications. As you can see, venous thromboembolism, sepsis, and DIC. We also looked at the cross-match to transfusion ratio, the CT ratio, which aligns with the national standard, which is less than 2. We looked at the decrease in wastage of blood products, and we developed revised policies for consent and refusal of blood products, and we developed a massive blood loss management tool that was implemented here at Jefferson for massive blood loss. The next slide. So our first aspect is to look at is our cross-match to transfusion ratio, which was very important. And you can see the red line is the benchmark nationally of less than 2. And when we implemented our program to look at blood utilization, we found that the cross-match to transfusion ratio actually decreased over the time period, as you can see when we implemented our PBM program, which was in the fourth quarter of 2014. And you can see that we actually went below the national benchmark of cross-match to transfusion ratio. And that was really focused on the MSBOS, the Maximum Surgical Blood Ordering Schedule, which we actually revised at Jefferson, which made the improvement in cross-match to transfusion ratio to be better assessed and managed. Next slide. If we look at spinal fusions, to give you a good example, we started off with blood product utilization, which was in the red line, and then, of course, length of stay being in the blue line. And for spine surgery, we looked at our blood product utilization, which was approximately 61%. And then after implementing our blood management program, this dropped to 45% and actually reduced the length of stay from 8.8 days down to 5.3 days. And this is a fairly dramatic drop on our spine service. Now, we had other services we did this with, but I highlighted spine because their blood loss and utilization, it was significant. But with a better approach to the process, we actually reduced the length of stay and the blood utilization, blood product utilization. Next slide. And the last aspect is our cross-match reduction in cost at Jefferson, and I'm showing you the Jefferson Neurosciences Hospital and the Gibbons Spine Surgery services, and we can see here that by implementing this blood management program, we were able to reduce the cross-match to transfusion ratio and saved a significant amount of money. Because the cost of cross-matching and not reimbursed, it's built into the DRG, is about $70 a unit. And so we were able, through our blood management program, to be able to reduce this cross-match to transfusion ratio, saving approximately, reduce our cost down to $14,560. I see the other dollar sign was cut off. So using this whole process, we reduced substantially our blood utilization as an organization across the campus. Next slide. If I can summarize now in our next slide, our key aspects, I think there's greater benefits than I can show on this short slide set we have, but clearly it showed some of the major areas such as spine surgery, cross-match to transfusion ratio, that we have made a major impact here. I think the success was improved with a committed executive sponsorship from the top, and most importantly, a dedication of the physician champion leaders that we selected to be part of this process. And this was preparing our health system to go live with this process because of all the organizations we'll be essentially reporting to, which would look at us being more fiscally responsible. And I think what we learned is most of the doctors that we dealt with never thought that they had problems with transfusing patients, but in this process, we actually showed that we could improve it. Finally, the biggest thing, this was a team effort based upon the beneficial aspects, and nursing, physicians, and hospital administration were all part of this process and this initiative. So I'd like to thank the organization for allowing me to present this. This is my email. You can email me. I'd be glad to send you our full slide set so you can review this. Thank you very much.
Thank you, Dr. Murley. Impressive work, great teamwork, and just having you on this call really shows the leadership commitment to this project. So thank you very much. At this time, we're going to move on to Diane Kimsey from Einstein Medical Center, and I'll hand it to you, Diane.
Thank you. This is Diane Kimsey. I am the clinical educator at Einstein Montgomery in the interventional platform and the surgery center, and soon to be the Bluebell Endoscopy Center. And I'm delighted to be here today. Next slide. Okay, so why is this important to us? Why did we get this started? Back in 2014, a wound and ostomy nurse was brought on board here, and I've been working in the operating room for 40 years. And we never thought about pressure injuries as something that happened to our patients because we don't see them here. They develop 2-3 days down the road. So when the patients leave us, we don't realize that we're causing them damage. So when the WOCN came on board, she looked through the data and she saw about 9 patients that she thought that she could connect with our operating room. And I was shocked. And there was nothing that I could say really because we weren't doing any assessments or any risk assessments on our patients. So these are never events. The Joint Commission, these are things that should never happen to our patients. We do not receive reimbursement if a stage 3 or a stage 4 pressure injury happens in our hospital. And that's about $40,000 above and beyond the care that the dollars for care that we give to the patients. And about 2.5 million patients a year develop pressure ulcers in the hospital. And about 60,000 of those will die as consequences of their injuries. And they are a very highly litigated hospital-acquired injury. Next slide. So the things that made this so successful, I think, for us, were we had senior leadership support. And the reason that for us that senior leadership support is so important is these products cost money. You need to know the evidence behind them. So when you go to your senior leaders to say that you need positioning surfaces, that you need bed surfaces, that you need preventative dressings, all of those things cost money. So you need to have the evidence so you can go to your senior leaders and get these things. What we needed to impress upon them is the money that you pay up front is really going to save you money in the long run. The next thing that's really, really important is having every department that touches your surgical patients involved around the table to put your program together. It's important because it's not just perioperative services. It's the people that bring the patients in, and then the wound and ostomy nurses need to close the loop for us and let us know what's happening on the floors. And staff buy-in is very, very important. We've been very lucky. This is a nurse-driven program, and we have had huge buy-in from our staff. We've been very successful. We've had a 75% reduction in our hospital-acquired pressure injuries, and that resulted in a 43% decrease in our unreimbursed costs. And actually, it's a little bit improved since we put these slides together. We had, when we started out, the 9 injuries that you saw in 2014. We had 4 in 2015, 2 in 2016, and we had 1 in January of 17, and we have had none since. Next slide. So how can you replicate this within your organization? It takes a lot of patience as far as education, because there's a lot of education. Our nurses, wherever our patients come into the system, they do a head-to-toe skin assessment. This is important because your patients may come into you with existing skin injuries, and if you don't treat them and document them fully on admission, if they're found down the road in the hospital, they're considered hospital acquired, and that costs us lots of money. We do a risk assessment on every patient. We have high-risk indicators, and what this is in our organization is we put a different color bouffant hat on our patients if they've been assessed as a high risk. That way, if the S-bar breaks down, they know that the patient is a high risk. We have a lot of integrated evidence-based preventative processes. We put dressings on our patients' sacrums and heels before they go into the OR to prevent these injuries from happening. We have a lot of positioning programming in the operating room. And I said before, the documentation is so important of all the nursing interventions. We audited 100% when we first started the program. Now we're doing 10 random audits per month, and we have great compliance. And this is part of education when people are brought in for new employee orientation. And if we find anything in our audits, we add that to education, and then it's a yearly education thereafter. Next slide. This is my contact information. Please, if you're putting together a bundle for perioperative pressure injury reduction, please call me. I would be delighted to help you with your bundle. And that's all I have.
Thank you, Diane, for sharing. That's great. I love the innovative, the bouffant different colors, and really important about getting staff buy-in and compliance across the organization. Thank you. At this time, I'm going to hand it off to Dr. Heery from Temple University Hospital, and the floor is yours. Dr. Heery, are you off mute?
Now you got me? There we go.
Now we got you.
Okay, sorry. Okay, hi everybody. So I'm Megan Heery. I'm the medical director of the Well Baby Nursery at Temple Hospital, and I am a general pediatrician. Next slide. So the issue in Philadelphia is safe sleep, and this is actually from the Philadelphia Department of Public Health, where they've tried to start a public health campaign around safe infant sleep, because in Philadelphia, 1 baby dies every 12 days due to unsafe sleep. The most recent numbers we have are from 2015, and that's 35 cases. So when discussing this with our patients, we often tell them it's basically 1 kindergarten class that won't be there this year. The interesting thing about these sleep-related deaths are that nearly 7 out of 10 of them were put to sleep in an unsafe place, most often in an adult bed, and more than half of them were co-sleeping, which is sleeping with another adult, older child, or another infant. Next slide. So as a result of this and other preliminary research we did, we created the SAFE-T program, which stands for Sleep Awareness Family Education at Temple, and it's pretty simple in design. There are 2 components. There's an educational component and then a baby box component. They were started at different time periods, but both work interconnectedly. So the educational component started February of 2016. We then later began distributing a baby box. Next slide. The educational intervention is a group of specifically trained nurses that go room to room on the postpartum floor to educate mothers on safe sleep. This is depicted here as a 5x7 magnet that we give out to all our mothers that reinforce the points of safe sleep. They then also get a graduation certificate that they graduated from the SAFE-T program, and all of this education is documented in the medical record. Next slide, please. The second component, which is where our novelty lies, is the baby box. So a baby box is literally a cardboard bassinet. It has a mattress and a sheet, and then also we fill this with essential baby supplies. Most of this work is done by volunteers and also the nursing staff. The baby box itself is a concept that's been distributed in Finland since 1938, although it's over in Finland, it's more of a maternal rite of passage as part of a central government social network. For us, though, we took it and took a little spin on it as a way to reinforce safe sleep, which we were the first in the country to do so. These boxes we purchased through the Baby Box Company, which is a company based out of California. For every baby that is born in our hospital, they receive a baby box. So if you have twins, you get 2. And we did this universal distribution to reduce social stigma associated with that could come up with if you qualify for a box, then you have to put your baby in cardboard. We also do an instructional video that is for the use of the box and is given to the parent on the day that they go home from the hospital. Next slide. So our key factors for success are definitely multidisciplinary support. This comes from every level, starting at the executives of the hospital, down to literally the guy in the garage that takes them off the truck, and everything in between that makes this program happen on a daily basis, because we do discharge about 10 to 15 newborns per day. So this is a lot of effort. Secondly is funding, because we do purchase a lot of the items that I discussed previously. We've had some funding from grants. We've had a lot of private donors. We've had an internal Temple University Kickstarter type of campaign that's been running for now 2 years. So the funding has come from a number of sources, including the hospital. Next slide, please. So the biggest thing that we realized in replicating for replication purposes is we changed our postpartum education that the nurses were providing to the mothers, in that previously the safe sleep education was included in standard discharge instructions. After a result of our preliminary research, we realized that if mothers perceived sleep education as separate or adequate compared to no education, then they actually did better sleep environments for their babies. So the first step we did was that educational component. And then for the baby box, the logistics of the supplies are really the biggest hurdle day to day, quarterly when we pack everything, the distribution, the setting up of volunteers, all those things need a lot of people and moving parts to get into place. Thank you.
Thank you so much. I have to say I love this program. I do imagine that the packing of the boxes could be quite an event as you're getting everything ready, but really a well-needed program. Thank you. At this time, I'm going to hand it off to Holy Redeemer Health System, Ravi Douglas. The floor is yours.
Hi, this is Ravi. I am the Pharmacy Clinical Coordinator at Holy Redeemer Hospital, and I also manage the antimicrobial stewardship program here. So antimicrobial stewardship is not a new concept, but the real issue here was determining how best to implement a successful and robust program in our community hospital setting. So the diagram is just showing our model of our prospective audit and feedback. So basically, once an antibiotic is prescribed, it triggers a pharmacist review. The pharmacist will then select certain patients to show the infectious disease physician for further input, and then the stewardship team will round on these selected patients and make appropriate recommendations to the providers, and these recommendations are either accepted or rejected, and then the cycle starts again. Next slide. So why we pursued this initiative, it really, the impetus was the CMS, or Centers for Medicare and Medicaid Services, requirement that all hospitals have some sort of program by January 1st, 2017. So this was really the impetus that put it in our senior leadership's radar and made it a priority. There's plenty of evidence out there showing the benefits of antimicrobial stewardship to the individual patient, the institution, and also in terms of population health management. And some examples are listed there, such as decreasing C. diff rates and improving resistance patterns. Next slide. Our key factors for a successful initiative really started with evaluating what resources were available. Once again, we're a small community hospital. We don't have medical residents. We're not a teaching hospital, so we really had to look at who the key players were. So senior leadership commitment was very important. The multidisciplinary team was formed, including the physician champion, the clinical pharmacist. We also have a person from micro, quality, as well as IT. So the pharmacist part is really the frontline evaluation of the patients. So this is really important. And then we also have our physician champion, which I just want to have a shout out to Dr. Rick Tepper, who he's so passionate about this and also has a very good rapport with his fellow colleagues, which makes this program much easier to implement. Also, from the IT perspective, we needed a program to identify the patients. So we actually have something called TheraDoc, but there are other programs out there that can help find these patients on antimicrobial therapy, whether it's running a report off of some sort of electronic health record. Once again, we're focused on the community hospital aspect. The majority of our patients are managed by private practices, some of which are hospital-owned and some are not. Next slide. For replicating this initiative, we really honed in and focused on the Centers for Disease Control and Prevention core elements. There were 7 of them, and they're listed there as the roots of that tree. also, to replicate this, is determining realistic, measurable objectives. So we really wanted to target the low-lying fruit per se first. One of our goals, for example, was decreasing the usage of fluoroquinolones. So something we can actually measure and show improvement on. And then also the very important aspect of this initiative is our day-to-day activities. So we talked about the perspective audit and feedback, and then our physician-to-physician communication, I think, is also what helps make this program so successful, that they are hearing our recommendations from another physician. Okay, and that is all I have. Thank you.
Thank you so much. I have to say I love your visuals and everything that you, how you presented this. Thank you for presenting. Now we're going to hand off to Jonathan Scheinfeld from Temple University Hospital. Jonathan?
Yeah, thanks, Liz. I'm the perioperative PI manager here. I'm in the room with Dr. Tom Santora, Vice Chair of the department, and Betty Craig, our Chief Nurse Executive, is also on the call remotely. Could you go to the next slide, please? So our project focuses on reducing post-op respiratory failure. Fortunately, this is relatively uncommon. 1 or 2% of SIRD post-op patients experience this complication, but unfortunately, across the country, about 30% of those folks die, and conservatively, it costs between $50,000 and $55,000 excess cost per case. And our results at Temple were no different. When we look at post-op respiratory failure, we look at it in 2 ways. One is through administrative data or coding data that's reported by AHRQ as patient safety indicators. I mean, using AHRQ algorithms as patient safety indicators, PSI 11, and also through the National Surgical Quality Improvement Program. Could you go to the next slide, please? So conceptually, we divided our team into 3 phases: pre-op, intra-op, and post-op phases. Pre-operatively, our emphasis is on risk assessment and risk mitigation through a very, very thorough history and physical process in PAT, and by identifying patients who are at greatest risk of developing respiratory complications, for example, active smokers. The second major emphasis preoperatively is on education for engagement, and we educate our patients in a variety of ways. We offer them education in a variety of ways. We have written material, and you can see the cover of a booklet that we developed there, and that's written in English and Spanish. We use electronic formats with audiovisual files that we push out to patients through the patient portal, electronic portal that they can pick up and watch on their own, maybe when their anxiety levels are lower than they are when they're seeing their physician. And we reinforce education throughout their stay, particularly in the preoperative phase. Also in PAT, patients are given incentive spirometers. They're taught how to use them, and we measure their preoperative volumes there. Intraoperatively, there's a number of anesthesia protocols that are in place. You can see them on the screen with fluid balance, antiemetics, and that's to minimize risk of aspiration. Multimodal pain management, and that's an initiative that's evolving into opioid stewardship. And of course, normothermia. Can you go to the next slide, please? Postoperatively, we use that novel mnemonic that's on the right, recover, as a teaching tool, and that helps us establish patient educations. So we create expectations among our patients about education, about pulmonary toilet with using the spirometer and coughing and deep breathing, about oral care, getting out of bed, walking, eating and drinking safely, which means nobody lays in bed to eat. Everybody is out of bed or minimally sitting bolt upright in bed to eat. So you can see those expectations. Once we create them, it's on us to live up to those expectations. And again, early mobilization, early feeding, lines and tubes out, pulmonary toilet. Can you go to the next slide, please? The next couple of slides, 3 slides, I believe, are some outcomes data. This is administrative data. So you can see in fiscal 14, our OE ratio was almost 1.4 for post-op respiratory failure. And over the next 4 fiscal years, it dropped steadily till 0.34 in fiscal 17. And there's a slight bump up in the first couple months of this year. But because these are administrative data, some of the cases in there are not actually respiratory failure, but rather prophylactic reintubation. For example, a patient having a seizure in PACU. You go to the next slide. This is more clinically abstracted data. Again, you can see the trend from fiscal 15 through calendar year 16. There was a slight bump in the most recent data when we did a deep dive into this. Those are non-elective cases that showed up with both unplanned reintubation and vented greater than 48 hours. And the next slide, please. So the point of this whole initiative is to reduce post-op respiratory failure and therefore save lives and save money. And we were able to accomplish both. We extrapolate about 10 or 11 lives a year not lost to respiratory failure compared to baseline. And that translates into $1 million to $1.5 million a year in cost savings. And the last slide. Eddie, are you on the call? Eddie,
I don't believe she can. I don't believe they can speak because it's only the presenters.
Oh, okay. I'm sorry. So how would somebody replicate this slide? This initiative? Leadership support. Senior leadership support is key. These initiatives are developed by the stakeholders. They were not laid on top down, but rather grassroots and built up by teams. It took a long time to develop this, but we developed it for sustainability. And it says there other organizations can easily emulate these with senior leadership involvement and simple bundles of bundles. So the key components functionally are patient education, risk stratification, pulmonary, toilet through incentive spirometry, and early mobilization. Structurally, the key component here is incorporating this initiative into the formal organizational performance improvement program. So this is not an extra program, it's part of the basics of what we do. That's what I got. Thanks very much.
Fabulous. Thank you so much. And thank you for sharing such a complex issue with clear, efficient, and systematic outcomes and with great outcomes. At this time, I'm going to go to Jefferson Health Northeast, B. Layden. Thank you. It's all you.
Hi, good afternoon. My name is B. Leiden. I'm the Director of Nursing Clinical Practice and PI at Jefferson Northeast. Next slide, please. I am a part of a multidisciplinary team that has been working on this project around progressive mobility in the critically ill patient population. We did define early on some goals that we wanted to address with it, generally looking to decrease complications in this patient population, but also looking to reduce length of stay, time on the ventilator, ventilator-associated events, pressure injuries. We wanted to prevent falls with injury as we were mobilizing people. That was a concern that the staff had. And the staff also had a concern about staff injuries as we started to get more aggressively mobilizing this patient population. Next slide, please.
Yeah,
so then a really important piece that I think led to the success.
See, I'm going to interrupt for 1 second. Somebody is not on mute, and I'm just going to ask everybody to check and make sure their lines are muted at this time. Sorry for the interruption, B.
Oh, no problem.
If I were over there.
So a really important portion was leadership commitment And we had leadership support from the inception of the project. And I think that, as many of the previous presenters discussed, that this was really valuable and sort of a critical piece to have success with the project. We had a group of critical care nurses who attended a national conference, came back energized, excited, with great evidence-based information about several initiatives. One of them was around progressive mobility. And our CNO had encouraged them to put a presentation together and bring it to the senior leadership team. They did that, and they were able to get support from that team, because part of the implementation involved spending money, as again we've been discussing through several of these presentations. So we were able to get support to get specialty walkers and ceiling mounted patient lifts, which is you know, a costly adventure. So next slide, please. I think something that was helpful in terms of keeping us on track with implementation was following a methodology for implementing evidence-based care. We used the Iowa model, and basically that did guide us through the process from early on identifying our knowledge triggers, getting leadership support, doing a pilot, and then actually then following through, monitoring our data, making some rapid cycle improvements along the way. And then finally, the last piece is dissemination, which is what we're all doing today. Next slide, please. So there was a lot of literature we reviewed. This is one key article on the ABCDE bundle, and one piece of that where we had felt we were lacking was this early mobilization and ambulation. And since then, the F has been added on for family, and we actually do engage our family members. We provide a family menu, which lists things that they may be able to participate in patient care while they're in the ICU, things like passive range of motion, some basic oral care, things like that. And then we help the family members if they're interested in learning how to do that. Next slide, please. So our plan, we chose a progressive mobility protocol. It was a 5-phase protocol, and it started with very simply, phase 1 is really just ensuring adequate airway and ventilation, and sometimes the sickest patients, that's all they can tolerate. The next phase goes on to a tilt, almost like a tilt table, and patients can actually do partial weight bearing up to 40%, just being in that tilt position. And then it goes on from there to sitting, standing, ambulating. Again, we had a multidisciplinary task force, physicians, physical therapy, nurses, lots of folks involved. Other key folks were our IT department, supply chain, many people involved in making this program successful. So we piloted at our Tarsdale Hospital in March of 2016, and since then we've been able to implement it at our other campuses as well. Next slide, please. So results, one of the key ones was our length of stay. We were really able to see a significant decrease there from 3.69 down to 2.92. So that was a 0.77 day decrease, which when translating to money, in the literature you can see a hospital ICU stay may be $3,000, $4,000. Multiplying that by the number of patients you see a year, it translates to millions of dollars in cost savings. We were able to see a decrease in our ventilator-associated events, pretty dramatic, stepping down pretty well over since our calendar year 15. And our mean ventilator days, we had decreased by a full day, and we've inched up there a little bit, but we're still well below where we were prior to implementation of the program. Next slide, please. So since the implementation, we're actually to make this a nurse-driven protocol. So once the intensivist reviews the patient and feels that they're a candidate for the program, they order that protocol. And most of our patients are ordered the protocol. We were also to be able to create a electronic documentation in a flow sheet format, which is really great that people can see progress from beginning to end in the electronic medical record. Again, we've been able to replicate in the other ICUs in our organization. We continue to monitor our outcomes, and we've had no pressure injuries, no falls, no staff injuries, and we haven't had any ventilator-associated pneumonias. We've had a few other VAEs, which is sometimes high-level changes in PEEP and stuff like that, but no actual pneumonias. So, and then the last piece is taking the show on the road, and I appreciate this opportunity to share our information and the recognition that you provided for us. We're really grateful and humbled by that, and we appreciate it. Next slide, please. Oh, And last, this is, we had permission to take these pictures, but we still decided to blot out the faces. This is just the process in action. If you see that picture on the left-hand side, that's our ventilated patient out in the hallway with several of our nurses and one of our intensivists behind helping that patient along. So sometimes it's a picture's worth 1,000 words. It's sometimes really great to see this process in action when you're walking through the hallway, seeing people ambulating, seeing people out in the chairs, even though they're critically ill. And I think that's everything I have. Thank you so much.
No, thank you, and thank you for sharing the pictures and giving us that visual. And I think it's a real sign that you're able to replicate this throughout your other organizations and other ICUs, and it really shows that it can spread across the region as well. So at this time, I'm going to hand it off to Temple University Hospital with Leah Keller.
Thanks so much. Hi, my name is Leah Keller. I supervise our Office of Patient Experience at Temple University Hospital, and I'm going to speak about how we engaged our frontline staff in customer service training. Next slide, please. So what we did is we wanted to look at our employee engagement scores because our scores were pretty low, and we wanted to look at that because we were embarking on a customer service journey, but as the Office of Patient Experience, we decided that we couldn't have the lowest scores when we were asking other departments to raise their scores and look at their customer service strategies. So our goals were to increase our employee engagement scores, and we really wanted to empower our staff. We wanted to be transparent through our leadership and enhance our team dynamics. And we wanted to develop that organic training curriculum with our organizational development team. And we wanted to disseminate that throughout our healthcare organization. Next slide, please. So we had to look at the factors for how we were going to do that. We had staff that had been here for quite some time. Many of them had been here for over 35 years. Some of them were newer to the team. Some of them were here for 5 years. So we started with an open door policy and daily huddles after reviewing our advisory board employee engagement results. And so we had the open door policy and had our staff come in at any time. They felt more welcome to come and speak to us as managers. We also held monthly team meetings and we had attendance reviews. So whereas before staff didn't know where they stood with a point system that our health system has, and they would be blindsided if they got a write-up for time and attendance, we now handed out monthly how many points they had based on their time and attendance coming in late or calling out sick. And again, after working with ODL, we developed a customer service training and piloted it with our team. Next slide, please. So here are results. After having the first employee engagement survey in October of 2014 versus January of 2017 after implementing these factors. So we had 0% disengaged employees versus 6.3% of disengaged employees from 2014 to 2017. Similarly, 53.3% of our employees were engaged versus only 38% in 2014. Next slide, please. One thing that really stood out to us was that many of our employees were really disengaged due to the fact that certain people, and many of them were doing this because they didn't realize it was a problem, came in very late or called out anytime they had an issue. So what we did is we started tracking the time and attendance of all of our staff and shared it with them. As I said, we were very transparent and really taught them better ways that they could use their time and attendance. And we sat down with each and every staff member and talked to them about work-life balance and what it meant to be on time and how important that could be. So as you can see, our numbers dropped considerably and people stopped calling out and started to come to work on time. Next slide, please. So replication for this, it was a very long journey for us. We didn't have a great relationship with our staff to begin with, but from then to now, things have changed considerably. Our partnership with HR is key for us. We work with them all the time and we try and put our employees first. We are always actively listening and have partnerships with our employees, and we see them really as partners. We empower our employees. We worked on that customer service training, but we encourage them to take other classes within our ODL program. Again, we continue that open door policy. We focus on education, and we now spend time together outside of work. Below you'll see two pictures. One is just a bowling outing that we did with friends and family of the staff. And on the right is a customer or a community service event we went to at the Gift of Life Family House. So that's what we've done, and it's been really wonderful for all of us. Thanks so much.
Thank you, Leah. Thank you for sharing that and impressive results in regards to the lateness and the call-out rates. It's impressive that you were able to bring this out of the department and across the organization. So we started with Jefferson, and we're going to complete with Jefferson. And at this time, I'm going to hand it off to Craig Sunholzy, who will be our last presenter, and then we'll open it up to questions.
Thanks, Claudette. My name is Craig Sunholzy. I'm the Medication Safety Coordinator at Jefferson Center City, and I'm going to talk about our program of implementing an IV workflow system to prevent pharmacy dispensing errors. Next slide, please. So historically, we used a method of checking the IVs that were compounded within the pharmacy called the pullback method. And in this, the technician would prepare the IV and then would draw the syringe back to show us the amount of drug that had been added to the bag. Now, the problem with this is that you obviously can never assure that what they pulled the syringe back to is what was actually added to the bag, or the drug was the correct drug. Several years ago, we had a harmful event involving a pediatric patient here, which had been checked using the pullback method, which failed in this instance. So we eliminated that in our pediatric population and required everything be checked before it got added to the bag. But that still left our adult population without the same safety procedures as our pediatric population. So we wanted to implement a system where we could check everything proactively, and we also, in addition, wanted to promote efficiency in our IV product preparations and minimize waste. Next slide, please. So our system consists of a number of things. The system interfaces with our electronic health record, and it queues doses for just-in-time administration. So 4 hours before the doses actually due, it comes into the queue. Whereas previously we were preparing doses on an every 8-hour basis, and it could be as much as 16 hours before the dose was actually due. So the system removes discontinued doses prior to being prepared. We use barcode technology to assure that we are adding the correct ingredient into the IV. That's done prior to compounding, so the technician would receive an alert if they were scanning a medication that was not correct for the IV that they're preparing. This process standardizes the preparation, so we could have had technicians preparing medications in different ways. This sort of takes them through step by step how they should be preparing a given IV. They snap pictures as they go through the preparation process, which is maintained. The pharmacist then can review these pictures afterwards. It doesn't have to be done right at the same time. It can be done remotely by the pharmacist, and they can see then actually the volumes used, the drugs used, final products, the labeling, everything. And then the final step is that our technicians, as they deliver these products, can scan the drugs into the location where they're putting them, be it the Pyxis machine, the refrigerator, so that we have a record of exactly where the product is. So if a nurse calls looking for a product later, we can say that that product is in the Pyxis machine and tell them exactly where it is. Next slide, please. So once we implemented this, we compared the error rate that we had in the year prior to implementation to 8 months after, and we decreased our error rate by 60%. And moreover, what we found is the errors that we did see were all instances where the technology had been bypassed. So we put some additional rules in place for what the allowable bypasses were. As far as implementation in other systems, we chose a comprehensive system consisting of all the steps that I've previously outlined. There are electronic health records on the market now where you can do pieces of this system. For example, barcode scanning to assure that you're using the correct product in preparing your product. The electronic health record that we use currently at Jefferson will be introducing a system very similar to this in their next version. So I assume the others will be doing the same thing as this is becoming more of an issue. And that's it.
Craig, thank you so much. What a intense project. So many facets, from technology to your process flows to different ways to be innovative and picture taking in the process. Thank you for sharing. At this time, we're going to read through our question and answer section. I do have to make a comment. I'm sitting here with Liz Owens and Pam Braun, and you know, Pam made a comment how impressed she is in regards to how different these programs are, or these projects were, these award winners. Very different team members presenting in regards to lessons learned from us and different views and different viewpoints. So thank you to everybody for this and contributing to today's webinar. I am impressed with, there's a lot of lessons learned here. There's a lot of pearls for us to share. And I wonder, even from the presenters, it does not look like we have any questions in our queue box right now, which Liz has up. Is there anyone who is a presenter who has a question for another presenter? Because you can speak. Okay. And that's okay. We don't have to. We thank everybody for their time. Liz, you were going to pull up the last slide. I'm not sure they can read it with everything in front of it. And at this time, I'm going to let Liz introduce the 2018 Safety Award and next steps for that. And please feel free, if you have a question in the meantime, don't hesitate to ask.
Hi everyone, this is Liz Owens. As Claudette mentioned earlier, I'm joined in the room by Claudette and Pam. I'm a project coordinator at HCIF, and I've been the one probably communicating with you for the past year for the 2017 program. We're excited to announce that we're moving forth with the 2018 program for the Delaware Valley Patient Safety and Quality Award. Call for entries, just a big shout out, a big alert, will be distributed sometime this week. So please keep an eye out for that email that will be circulated from our organization. And we're moving forward with that. So we're very excited. So keep an eye out for the 2018 call for entries. I think at this moment we don't have any questions. As we said, for those who are attendees, please, if you had any questions, submit them through the Q&A or the chat box, as you cannot speak through this webinar platform, but we're not seeing any. So I think at this moment, that concludes our webinar. We thank all of our 8 presenters for taking the time to really share their initiatives, their award-winning initiatives. And we hope that everyone will keep an eye out for the 2018 program.
And thank you, Liz, for putting together 8 different presentations in less than an hour. So that is an accomplishment. That needs an award in itself.
All right. Thank you, everyone. Have a good day.
Thank you. Thank you. Thank you.
Thank you.
Good job. Good job.